The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, incidents by the numbers.
We're losing all sorts of opportunities by not reporting within our system to improve them.
That's Dr Lynette Knowles, the medical lead for patient safety and quality at Clinical Excellence Queensland and former Executive Director Transformation, Analytics and Governance at Darling Downs Health. And I'm presenting her with a difficult scenario.
When you have a patient who has permanent harm as a result of healthcare or dies as a result, there is a lot that we need to do.
In today's scenario, you receive an email from a plastic surgeon raising concerns about a patient who needed to return to theatre to repair a significant skin tear that was created when their dressing was removed. The surgeon indicated that this is not the first one they have seen, and staff needed to be educated about the risk, as these injuries can have long-term consequences for frail elderly patients. You look up the incident reporting system and notice that a nurse created a report classifying the incident as minor. The incident was subsequently closed with no apparent investigation or follow-up. Undertaking a quick search, you notice that there have been multiple similar incidents reported over the last 6 months. I started by asking Dr Lynette Knowles what issues this scenario raises.
The first thing I want to call out as an absolute positive, it's not necessarily an issue, but the fact that my plastic surgeon has picked up the phone or emailed, in this case, to highlight that there is an issue, I think is a matter for celebration. It's really great, and I think that is a positive to be celebrated. In terms of the issues and those things that we think, there are areas for improvement here, I think the issues that we have are the identification of a patient safety issue in the first place, both for the elderly patient who's being returned to surgery and the ongoing consequences that patient will have. But we've also got the patient safety issues in the systems wide view. So we know that there have been multiple issues which have been raised with similar circumstances, and we've not had the opportunity to look at those multi-incidents to see if there's anything trending within our system. And of course, by doing that, we could, as the surgeon pointed out, expand our training, but also look at our procurement. So we're losing all sorts of opportunities by not reporting within our system to improve them. And then we have the issues of clinical governance. So our systems and the supports around clinical governance to ensure that the care that we're providing is safe and high quality. And then finally, it is that bravery and courage to speak up and to report and to step forward, which is also a big culture piece. So that's probably the third large issue that I'd be looking at.
In healthcare, we love to give things numbers because we can quantify them. Can you quickly explain how incidents are classified, the ISR or the SAC or 1 to 4, how are they determined whether it's a 1 or a 4?
Oh, we do love a good category, don't we? So number 1 is the most severe. That's a permanent injury or death, which was not reasonably foreseen as a result of healthcare. SAC 2 is temporary harm, also not unreasonably foreseen within healthcare. And then we move down to more temporary harm, and SAC4 is a near miss. So the great things about categorising is it makes it easier to communicate what we're talking about and gives a general sense of the risk. So that's the severity and also the consequence, as well as the likelihood of an incident happening. But it allows us in really clear terms to understand what kind of resources we put towards the review and investigation and ongoing follow-up as well. Of course, the SAC1 reviews and also follow-up takes a lot more resources, far more intensive for an organisation. So it's a really excellent categorising system that gives a lot of information and communicates more than just the severity of the incident that's happened.
So the nurse who put this report in classified it as minor, probably a SAC3, and yet the patient had quite permanent harm. They needed a skin graft to repair the damage, and that required a return to theatre. How can you assign a minor to something that had such an impact on a patient? And I guess it was eminently preventable.
Yeah, I think both of those are concerning, David. Again, I'll start with a celebration. The first thing is getting into a risk man system, or a system where our incidents are being reported, gives us clarity. If this nurse had never reported this particular incident, we wouldn't have had any oversight of the event, or very limited until the plastic surgeon had got in contact with us. So I think the first thing is to really point out that reporting, whether we get it 100% right or not, is an important thing in this case to have been done. So as incidents are coming in, there are people, in a good system looking at these reports as they come through and monitoring and checking. The other thing that I would also say is sometimes we don't know at the time the consequence, and we don't know at the time the outcome. And sometimes in the reverse, we can see a particular incident has happened and think it's an incredibly severe event, only to find out that it actually was only temporary harm, or there were other factors around the care that we needed to be keeping in mind. So I think in both ways, we can sometimes get it wrong, but getting it wrong is not necessarily the issue in terms of classification. Getting it into the system is the most important thing to be concerned about, I think.
So SAC1s require a significant investigation. SAC2s require a case review. SAC3s and 4s usually just get noted. Tell us about the implications of a SAC1 and the investigation that is consequent on that.
Yes. So as we mentioned before, the categorisation really allows an organisation to systematically put resources behind an incident when it happens. So when you have a patient who has permanent harm as a result of healthcare or dies as a result, there is a lot that we need to do. We need to assess and quickly triage the situation. I like to think about it in three ways: a triad of safety. We need to think about the patient or the family and what they need next, whether it's further care or whether they need support or ongoing connection with the hospital. We need to think about the staff. So when a severe event like a SAC1 has happened, how are the staff coping? Do they need a debrief? Do they need some support? Do we need to bolster the roster? And then we need to think about the organisation, which is, are there public relations issues? Are there legal matters here? Are there reporting and regulator obligations we need to think through? So there's a whole cascade of things we need to think through. And by registering a SAC1 or reporting a SAC1 through the system, what happens in the background is a triggering of all these systems, including triage meetings where we work through much of that triad of safety, and we work towards the best review and the best approach to support patients, staff, families, and the organisation as we move through. Of course, once we start a SAC1 review, that's 3 months of working through our report. So that's 3 months of, intensive investigation or review of the incident, but also ongoing open disclosure and communication with the family as well. So I think in Victoria, we call that duty of candour. Yeah. And so that system also is triggered. So the SAC1 really, it alerts everyone to a number of resources that need to be mounted, an amount of support that needs to be wrapped around everyone involved in that incident.
Implies there's quite strong incentives for nurses to understate the severity. If you can give it a 3, then it just gets closed. If you give it a 1 or a 2, then all hell breaks loose, investigations everywhere with recommendations. How do you make sure that the staff entering the incident assign a realistic and appropriate severity?
Yeah, I think what you're pointing out there is culture, isn't it, David? There are some health services or experiences that people have in health services where they feel they're going to be blamed for the incident or will have a consequence or a repercussion as a result. And that is, very personally challenging for people, and it will definitely challenge their willingness to report and participate within safety and quality. At the other end, we have those organisations who use restorative just culture or an open learning culture where everything is welcomed in terms of reporting. Having a good, clear oversight of that system helps too, to make sure that our reporting is on target and it's accurate and appropriate. But there are no reprisals, that it's not punitive to put in a report, and that actually it gives us a visibility of our systems that are otherwise invisible if we don't have those reports. I do take your point, though, that nurses largely put in the entries to the risk man, and I think that's an important point to pull out. And I would say that in a system which is working really well, with a reporting system which is incredibly usable and user-friendly, those things make it much easier for everyone to do the right thing and invites people in. But again, I think a risk or an incident reported is much better than one not reported, even if it's reported by the nurse rather than the treating clinician. But there are lots of things there that I think, for the nurse needs to support and wrap around that nurse as well.
One of the consequences of nurses being the ones that usually enter the reports is that doctors may not be aware of what the nurses said and may at times disagree with what the nurses put in there. How do you make sure that doctors are involved? I guess it's particularly a problem in private, where doctors don't have hospital emails, they can't really be linked into the riskman system, and so they don't get alerted that an incident's been entered around their patient. How do you make sure that doctors are involved in this reporting and incident system?
Well, onboarding, I think, it starts from the day people start in the organisation, doesn't it? That's when you set the culture. That's when you're setting the expectations. And so really, I think it's a great point, a good opportunity to work with doctors about how they manage entry into the system, what the system looks like, how they're supported, and really, ideally, who they pick up the phone to when they have any problems. Again, it's lowering that barrier. It's helping people to do the right things really easily. That being said, there are, as you pointed out, in private, the doctors don't necessarily spend the large amount of time on the ward or in the building for that matter. They may be in their private rooms or, in other places. And so the nurses are the ones who input. I would, in those situations, really encourage the nursing team to pick up the phone and to bring the whole team in. Just because one person is reporting doesn't mean that there is no reason to communicate across the team that, an event has happened. And in fact, you'd be wanting to see these events being recorded and being noted and discussed in multidisciplinary morbidity and mortality meetings that will be happening in the craft group, but also within the ward setting as well. So that's another really good avenue for discussion, but also the introduction of further information and further case review, particularly for the SAC 4 through to 2. So I think there's a lot of opportunity for a lot of discussion. I would say that including the teams and the treating clinician and, those people most centred with the care of that patient and the family is absolutely critical. And I think that's when you draw out more information. Once a report goes in, you often don't have the whole facts. You just have your particular view, and it's only a slice of the whole situation as it will unroll or unravel throughout the review process. And so I think one of the risks we always have when a report gets put in by someone is that you don't actually have the full picture, and there needs to be a tolerance for that as well within the system.
What about letting the patient know? Should we let the patient know that an incident's been entered even if there was no harm?
For sure. Absolutely. Let me go back to the harm, because I think that's probably the easiest one to talk about. When we have a patient who has sustained harm as a result of healthcare, which wasn't reasonably assessed to be, then we absolutely have a duty to be open and frank with that patient about what's happened, and also to express regret, because the truth is no surgeon, no doctor, no treating clinician treats a patient with the expectation that things will go wrong or that the outcomes will not be, what we anticipate. And so that's an opportunity, and I think a really important opportunity for us to have open, clear, transparent communication, but also to support and build trust that something has happened, but something will be done. We are going to be looking into what's happened. We're going to be understanding it better. We're going to try and prevent it from happening in the future. But equally, your care is really important to us. And there's a whole heap of other things we need to plan about your care, but also help you potentially navigate going through the next period of recovery or however long it takes for support as well. It doesn't mean that we accept liability for all harm, because as I mentioned to you before, we often don't know at those times we have discussions about what exactly happened. And so we have to be very mindful not to speculate or opinionate, but to provide the facts that we have, but in truthful, transparent ways for the patient so that they can trust us and they can know that we are doing the right thing. So that's really key.
One of the challenges I have in the clinical governance process is we spend an enormous amount of time on SAC1s or ISR1s. And in fact, if it's a sentinel event, it'll even get reported up to Parliament and published to the numbers across the country. But we tend to ignore the SAC3s and 4s, and yet that's where an organisation can learn so much. I recently worked at an organisation that hadn't had a SAC1 for many months, and they were very proud of the fact that they hadn't. And yet when I went through their riskman system, they had had something like 30 or 40 medication errors that were all near misses or minors, and they hadn't been picked up. And I said, hey, hang on. I think we've got a lot more to learn from medication errors than we have from our last SAC1 catastrophic incident. How do we learn from these frequent events that happen every day rather than the very rare event that probably won't ever happen again?
You're right, David, aren't you? It's that tension between that really rare event but catastrophic event where a patient's lost their life or is severely injured, balanced against those things which happen more numerous but less severity. I would equally say this is a real conundrum, I think, within our system, because the large number, the vast number of incidents are those SAC3 and 4 incidents. I would say a robust monitoring system behind your reporting system is an absolute must. So it's one thing to have a reporting system, but people have to be in that system looking at what's coming through, responding to the incidents and taking care of patients, staff and the organisation. But on the other hand, looking more holistically at the systems as well. So we'll see many of our organisations, in fact, all of our organisations will have reporting systems. So looking at the incidents, trending, seeing what's happening within them. So you'd hope that those medication incidents would be picked up through that trending and reporting analysis. And if they're not, that's a really good opportunity for us to look at our reporting systems and our communication systems from ward through to board. How is everybody understanding what the practice looks like for the ward, for the department and across the organisation? And where can we put our resources to best improve our practice? So that's really, really important. But equally, monitoring isn't enough either, is it? It's that response element. It's taking the action and improving how we provide care so that it doesn't happen again, or that we really reduce down the opportunity or likelihood of it repeating. So SAC3s and 4s, they're important places to keep your attention to improve quality overall, but they don't quite garner as much excitement as you've mentioned as SAC1s and 2s because, they're kind of the canary in the coal mine, aren't they, really, particularly those SAC4s. And so drawing attention out is really important.
The board at the end of the day is responsible for managing risk, and they need to be assured that your organisation has identified the risks and has them under control. What sort of incident reporting do you think is important to send up to the board?
Ideally, with your reporting, you would be wanting to provide analysis and trending across the organisation of critical clinical incidents. So we often use a term for boards, it's nose in, fingers out. So, they're really wanting to look at the system and monitor it, but without being operationally involved. So having that information, which is trended and analysed, provides a narrative about what is going on in the organisation. So you'd certainly be wanting to show the clinical incidents, 1 through to 4, the trending. You'd be wanting to also provide information about the reporting, particularly around SAC1s and how the reviews are going, but also SAC2s and other significant incidents as well, those which are high risk and high risk from a reputational or, public relation or legal risk, but also community confidence risk, I think, is becoming more and more important for hospital health services as we move forward. And then really looking at the totality of our clinical governance metrics. And my goodness, there are thousands of metrics that could be put forward, but having a good, robust system where you're marking off each of the important areas that for safety, quality and improvement is really, really critical, but also your standards moving forward. So if we were just looking at clinical incident management reporting, David, I'd be absolutely recommending this clinical incidents trending analysis and your SAC1 overviews. I'd also be including open disclosure or duty of candour reports as well, if there are anything that, was specific coming from those. The number which are being done, the quality of those and the outcomes, I think, are really important for boards to know as well.
I think it's so easy for boards to ask, who's suing us and who's damaging our reputation. Whereas for me as a board member, the most important question is, but what are you doing about it? What action is your organisation taking to head off this risk that you identified? It's all very good telling us that you've got a high rate of VTEs, but more important for me as a board member is what are you doing to address the problem?
Yeah, absolutely. And with those, I would add to, David, having oversight of the recommendations, I think, is critical. So those recommendations which are coming out of the SAC1 reviews, but also reviews at other levels, multi-incidence analysis. And I would also say, what is your organisation doing in response to coronial matters from across the state or other significant reviews which are happening both, within your state, across the nation and also internationally to really improve patient safety and service safety across the organisation too, I think is becoming more and more critical for boards as well.
There are other ways of tracking patient incidents rather than just the incident reporting system. And I guess one in particular is patient complaints and patient feedback. How do you integrate incident reporting, patient experience, patient feedback into a coordinated response to quality and safety?
I think many organisations nest their consumer experience or consumer liaison with their patient safety or clinical governance teams. And I think that is a really important move because it integrates them all together. Like once upon a time, our complaints used to be about car park sizes and smoking areas. Now they are the red flags in our system. They are where we're understanding about waitlist experiences. They're, the experiences on the ward and the way people are, experiencing healthcare through our organisations. And so more and more, they really are becoming the flags, the early warning tools, early warning signs that things are starting to bubble up. So I would say just as we take our clinical incident reporting and our monitoring really seriously, so too should we be taking our consumer liaison reporting or our, consumer feedback reporting because they are really important flags for us. One of the things that I think is also critical is these things are not happening in their own bubbles. So our consumers are having harm and there's entries being put into Riskman about that harm. They're also raising it through our feedback systems. They're talking to the Office of the Health Ombudsman or the complaints organisational regulator for the state. So there's a number of avenues where all of this is coming together and triangulating all of that information together is, I think, really critical in understanding what exactly is happening in terms of safety and quality and the patient experience. So understanding and responding to that is very critical. I think when you have a nested system with feedback and patient safety and quality together, you have the opportunity to really proactively respond, to support the patients and to improve the system as you move forward. And so I think, we're not at that period anymore where we can take each in isolation. They all have to come together to support each other in order to move forward. And I really do hold true to the realisation that, our complaint system is really our early warning system for a lot of safety and quality across the organisation. So you need to pay heed to that data when it comes up and act.
Thanks, Lynette. Absolutely agree. I'd like to finish with a difficult question, I guess, and that is, how do you as a person responsible for quality and safety know whether the system's working?
Oh, that is a tricky one. That is a fabulous question. I think you know your system is working when people can talk to you about the system, when people know that it exists, and when people pick up the phone and go, hey, Lynette, I think I've got a problem. You know your system is working well when your consumers are also coming to you and they're inputting into the system, not only from a complaints feedback perspective, but from a quality improvement perspective as well, because it shows you that you have engaged people along that journey from harm or near harm or something not quite being right, all the way through to an endpoint where you have an improved system and you have a system which is serving the people that it needs to serve. So I think it's not a metric. It's not a certain number of risk reports or a certain, number of quality improvement projects, but it is actually a culture. It's that feel that you have within your organisation that people know that their safety systems are there and those safety systems are actually improving the outcomes of people's care and also their experience within our health service, both for staff and patients, consumers and families and communities alike.
Thanks, Lynette. That really goes to the heart of clinical governance, moving away from compliance to culture and getting the culture of the organisation working to continuously improve outcomes for patients. Thank you very much for your time. Excellent discussion on the role of incidents and incident reporting in improving the services that we offer our patients.
Thanks, David. Great to be here.
That was Dr Lynette Knowles, the medical lead for patient safety and quality at Clinical Excellence Queensland. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.